I'm Peter Block at the American Heart Association annual meeting for On the Scene. We're here in Chicago, and with me is Dr. Dion Stubb from Melbourne. The AVOID trial is what Dr. Stubb has in fact talked about today, oxygen therapy and acute myocardial infarction. Dion, tell me about your study.
Thanks, Dr. Block. So the air versus oxygen in myocardial infarction, really looking at a fundamental first principle practice. For over 100 years, we've been giving oxygen to every patient with suspected AMI, pre-hospital, in-hospital first aiders, nursing staff. We all sort of jump to oxygen when patients describe any ischemic symptoms. And really, if you look at the evidence, there's very little, good clinical data. And maybe more concerningly, there's physiological studies that show oxygen only after 15 minutes via a face mask can cause coronary vasoconstriction, reduction in coronary blood flow, free radical production, and maybe increase reperfusion injury. So the AVOID trial was really asking the question, is our current practice of giving oxygen to normoxic patients with STEMI, is that potentially harmful with regards to myocardial infarct size and recovery?
Well, you're absolutely right. All of us throw an oxygen mask on every patient that comes in with a lot of pain, and who knows? So what did you find?
Yeah, so it was a pragmatic trial really organised by Ambulance Victoria. They've got a research group, do fantastic pre-hospital research trials, and in collaboration with 9 STEMI centres in Melbourne, we randomised 600 patients pre-hospital, and the inclusion criteria was patients with suspected STEMI, less than 12 hours of symptoms, and then they had to have normoxia, so oxygen sats more than 94%. Randomised to 8 litres of oxygen or no oxygen. That carried through to the emergency department cath lab, and then we measured infarct size on routine biomarkers of CK and troponin. And so when looking at the primary endpoint, which was on 441 patients with confirmed STEMI, we saw a 25% increase in CK release, and that was both for peak and area under the curve with a p-value of 0.01. We had a similar 20% increase in the troponin, but it's a non-significant result with a p-value of 0.1. So troponin non-significant, CK highly significant. We then, in a third of the patients, they agreed to come back for a cardiac MRI. We offered it to everyone, but a third agreed to come back for cardiac MRI due to pragmatic reasons at 6 months. And that same signal on MRI at 6 months was there. We had this 30% increase in late gadolinium enhancement with overall infarct size, and that was p-value of 0.04, so hypothesis generating. And when we normalise that for left ventricular mass, again the same signal but only a trend with a p-value of 0.06.
That's rather impressive, isn't it? It almost sounds as though coronary vasoconstriction plays a major role if your patients get too much oxygen. Is that just coronary regulation, or what do you think is going on?
I think there have been some very nice physiological studies really performed over the last 40 years that show that it's probably a complex mechanism of one, coronary vasoconstriction potentially protecting cells against oxygen toxicity, but then there are other issues, calcium modulation, oxygen free radical production, that all might be related to hyperoxia. We're seeing it potentially in the brain, heart and kidneys. So it may be, this I think just raises the question that should we think of oxygen as a drug? Should we prescribe it? Clearly it's useful for patients with hypoxia, but maybe we should be less indiscriminate of throwing it onto all patients.
Sounds to me that the teaching point here is if you come in, or your patient comes in, not you I hope, comes in with an acute infarct, watch out for giving them too much oxygen because in fact their infarct size may be larger. Fair enough?
Yeah, I think, look, 441 patients, there's certainly a signal. I think it needs to be confirmed with larger studies. A large Swedish trial powered for mortality is going to look at answering this question. But no, I definitely agree with you that we should be conscious of potentially over-oxygenating patients with normal oxygen levels.
There you go. Be careful of the oxygen mask when the patient comes into the ER. Thank you very much.
Thank you.